Good morning, good afternoon, good evening, wherever you are. My name is Fuad, Associate Professor of Public Health Practice in the Faculty of Health Sciences at the American University of Beirut in Lebanon, and co-director of Refugees Health Program at the Global Health Institute at AUB. I also serve as a member of in R2HC Funding Committee. It's a privilege to be the chair to this important panel on health system responses to COVID-19. How can we meet the needs of refugees and internally displaced people? By the end of 2019, almost 80 million people globally were displaced. Increasingly, refugees and internally displaced people are hosted by countries with few domestic resources, putting additional strain on fragile and under-resourced health systems. Anticipating the potentially devastating effects of the COVID-19 outbreak, in March 2020, ELERA launched a call for responsive research proposals through the Research for Health in a Humanitarian Crises program, R2HC. These studies will deliver evidence to meet the needs of operational actors and policymakers who are tackling the challenge of adapting health systems and COVID-19 public health service delivery. This interactive panel discussion will share unique first-hand learning and provide real-world examples of lessons learned from Colombia, Lebanon, and Palestine, identifying relevant insights and solutions for wider context. The first study, presented by Dr. Harker, aims to understand the adherence to public health and social distancing policies across 60 Colombian municipalities, as well as measure healthcare utilization and costs among Venezuelan migrant refugees and Colombian citizens in the same municipalities throughout the COVID crisis. The second study, presented by Dr. Diaconou, explores the resilience of UNRWA health system and health and social care workers, as well as Palestine refugees living in crowded settlements in Gaza and Lebanon in the context of COVID-19. Conducted in partnership with local policymakers, in partnership with local policymakers and practitioners, each study measures public policy effectiveness in preventing COVID-19, whilst also exploring specific approaches to strengthen health systems. It gives me a great pleasure to introduce our distinguished panelist for today, Dr. Arturo Harker, Associate Professor at the School of Government, Universidad de los Andes, Colombia, Dr. Karin Diaconou, Research Fellow at the Institute for Global Health and Development, Queen Margaret University, UK, and our discussant for today, Dr. Akihiro Sita, Director of Health Program at the United Nations Relief and Works Agency, UNRWA. For our audience today, and before we start, I just want to pay your attention that we will be asking a few questions throughout the session via the poll function, which will appear on the symposium platform or on the HSR mobile app. Also, audience can ask questions using this platform, the symposium platform, or the HSR mobile app. Now, I'm happy to introduce our first panelist, Dr. Arturo Harker. Dr. Harker is Associate Professor at the School of Government at Universidad de los Andes, Colombia, His research has focused on studying the impact of adverse experiences on a human capital development and on the design and evaluation of interventions that help mitigate this impact. He is a faculty affiliate of the Care and Protection of Children Learning Network and non-resident research associate of the Commitment to Equity Institute at Tulane University. Dr. Harker, the floor is yours.
Thank you, Fuad. I'm gonna share my... Well, thank you, now it's working. So it's a pleasure and a honor to be in this panel and to be able to share the preliminary advances of our study. This study, the title of the study is Strengthening the Human Response to COVID-19 in Colombia. The PI, the principal investigator of the research, is Diana Bowser. She's a professor at Brandeis University, also my co-investigator, Donald Shepard. I am an associate professor at Universidad de los Andes. So before going into the results of the research, I want to do a brief contextualization about where is it happening. So our research is conducted in Colombia. It's a country of almost 50 million inhabitants. The country is almost twice the area of France or Texas, whichever reference point works best for you. It's a democracy with a federalist aspiration. This is important for our research because its geopolitical division is important. It's divided in 32 departments. There are similar as the states in the US and 1,103 municipalities that are like counties where there are mayors that have some, they have local governments that during the pandemic did important work. And we're going to focus on this variation across municipalities. Colombia is almost, most of its population lives in the cities, around 80%. And in terms of socioeconomic development, the GDP per capita is around $14,400 US dollars. This is around 1/4 of the GDP per capita in the US. However, our income inequality is one of the worst among in the world. The Gini is 5.1. That's we're 12th it's the 12th highest in the world. And more than 1/3 of the population lives below the poverty line. Given the pandemic, this is expected to rise about again to what the levels we had 20 years ago, that is almost half of the population living below the poverty line. It is important to highlight that we have had decades of long conflict. After years of formal peace negotiations, Colombia signed a peace accord with the biggest leftist guerrilla group in November 2016. This accord was ratified in the Colombian Congress, and the accord called for members of these illegal armed forces to demobilize, disarm, and reincorporate to society. And there were a lot of commitment to reform the state in order to make space and to go to the territories where the government wasn't present. We still have the conflict. This didn't stop the conflict. We still have ongoing conflict between the government, paramilitaries, and insurgent groups. And this conflict is heavily funded by drug trade and illegal mining. So in terms of how does the health system work in Colombia, we have a social insurance system. that combines different types of affiliation depending on if you are formally employed or not, or if you're in a particular vulnerable population, you get a type of affiliation. All of these regimes have the same benefit packages. It works as a managed competition, and there's consumer choice. The performance of the system is actually really good. There has been a rapid progress towards universal coverage. In 1993, the enrollment rate was around 23%. In 2014, it was up to 96.6%. Also, it has achieved financial protection for the final user. The out-of-pocket spending was 52% in 1993. In 2006, it was down to 15%. It also has improved the access to services. If we see data for the poorest quintile in the population, the reported unmet health needs fell from 33% to 2% in 2013. However, there is always a financial sustainability. Financial sustainability is always a concern. 80% of the health expenditures in Colombia come from public sources. And we have seen in 2014, we saw that 45% of public hospitals were at a high risk of financial breakdown. And in recent years, 29 insurance agencies have to close. So this is an ongoing concern. So about the Venezuelan migration crisis, this crisis was started with the socioeconomic and political crisis in Venezuela. The estimates show that 89% of the population live in poverty right now in Venezuela. They have the second highest homicide rate in Latin America and the Caribbean. It's 89 per 1,000 inhabitants. Infant mortality rate rose to 26 per 100,000 live births. And it's estimated that in 2017, Venezuelans lost an average of 11 kilograms. That's a measure of nutritional and food insecurity. So about our study, the question that guides our study is, how does the implementation and uptake of policies among Venezuelan migrants and Colombian citizens impact COVID-19 response and healthcare access and utilization? These are photos taken mostly by professionals from UNHCR and the IOM all around Colombia, not only in the border. An important factor here to have into account is that migration has been much more intense in some places in Colombia, for example, in the borderline that we share with Venezuela, but also in other municipalities through which the Venezuelan migrants have transited, going to other countries in Latin America. So what are we doing in this study? So we want to determine the implementation and adherence to policies during the COVID-19 outbreak among Venezuelan migrant refugees and Colombians. And we want to determine how did this happen very locally at the municipality level. We want to determine the healthcare utilization costs. And we want to estimate the impact of implementation and adherence to policy. Finally, to inform decision-making related to the process of reopening, especially for countries with refugee and humanitarian populations. How are we planning to do this, or how we are actually doing this? We're halfway there. We have three components in the research. The first one is a desk review, where we want to do a characterization to understand what did these the local governments at the municipality level, what they did, what do they do to respond in terms of policy to the outbreak. The second component is a telephone survey, where we want to reach 7,200 people. At each municipality, we want to reach 70 Venezuelans and 50 Colombians, Colombians to have a reference point to understand what the Venezuelans say, how did they respond during the pandemic, and how well could they access the health system. And finally, we did an analysis of healthcare utilization data that comes from the insurance system. It's a database reported by healthcare providers, and it's consolidated by the Ministry of Health and Social Protection here in Colombia. So very briefly, some of the results. The first result is when we see and do a characterization at the municipality level, we see that there was the type and intensity of social distancing and public health policies vary a lot across municipalities. In the first graph on the left, we see the time, the 36 weeks we're analyzing, starting from the outbreak initiation. And what we're seeing, this is the count of the types of policies implemented at the municipality level. So if you see, the blue bars are the number of municipalities in each week that did a mobility restriction that worked through the ID of a person, the digits, the last digits of the ID, they were had a mobility restriction depending on your ID, the digits on your ID. And there were 32, we counted 34 types of measures or policies of social distancing and on mobility restrictions and other kinds of restrictions. So what we see there is that in time, this changes a lot and the type of policy varied. Also in the panel at the right, what we see is in the horizontal axis, we see what percentage of these 32 types of policies were implemented. So if you're far on the right, you're in a municipality where the local government implemented a lot of these types. For example, Bogota, that is the capital of Colombia, there we see that half of these types of interventions were implemented in Bogota. On the other axis, on the y-axis, on the vertical axis, we see a measure of the restriction in mobility. So if it's higher, it means that people were restricted and couldn't move through public areas. So this varied again a lot across municipalities. So that's one of our first messages. The second one, this is data from our telephone survey with 3,500 surveys made. And what we see here clearly is that Colombians and Venezuelans respond differently to these policies at the local level. We see that the knowledge, the first pair of columns show the comparison between Venezuelan and Colombians. And we see that knowledge of COVID was significantly different by nationality. The next couple is, we see that self-adherence and by social distancing measure was different across Colombians and Venezuelans. Sorry, this went back. And what we see is something really interesting is the last couple of bars. We see that the perception of others' adherence, not the own adherence, others' adherence in these measures of policy adherence was highly significant, different between Colombians and Venezuelans, but it was higher for Venezuelans. So this is the same data showing variance across municipalities. So if you see, the national measure was the one that I just showed you in the previous slide. Now we're decomposing this, the other, the square, the triangle, and the crosses show it for different cities, one of the largest cities in Colombia. And what we see is that the difference across Colombians and Venezuelans, and the sign of that difference, if it changes across municipalities. So there are very interesting phenomena happening within these municipalities. So that's something that we want to explore much more in our research. Another interesting result from the telephone survey is that we see that Colombians and Venezuelans report different experiences in accessing healthcare and medications. As you can see here, Colombians the percentage of Colombians that responded that their access to healthcare or to routine medications was more difficult since the pandemic started. For Venezuelans, this measure was lower. So that's interesting. You're going to see the utilization data next, and you can see that this difference may be because of there's a floor effect for Venezuelans. They couldn't be lower in terms of their access to healthcare and medication.
Dr. Arturo, 1 or 2 minutes max, please.
I'm
Thank you.
actually closing in 1 minute. So
Thank
during
you.
the pandemic, Venezuelans had a slight increase in healthcare utilization, but Colombians had a huge drop. If we're comparing in these graphs, they're not easy to understand, but I'm going to compare these graphs. On the right is for Colombians, and this is the count of hospitalizations. It's actually the rate per 100,000 population. And what we see is that between 2019 and 2020, if we compare the first trimester, we see that hospitalizations for Colombians dropped in 60%. So this is a measure of how much the healthcare utilization dropped during the pandemic. What we do in the other lines is we decompose this across ages, because there's an important difference because the Colombian system prioritized during the pandemic people that to provide services to people that were 70 or more, or people that had some preconditions. On the left side, we see the same data, but for Venezuelans, and we actually see it's almost flat. We see that there's actually a slight increase. So this is what we're seeing on the administrative data on health provision. And we want to decompose this analysis throughout the types of affiliation and much more. This is just the same, but for two cities, Barranquilla and Medellin. And again, we see considerable variation across municipalities. That's the main message I want to give on this. So finally, so we have these results. We see this important drop in overall healthcare utilization, but not so much for Venezuelans. There is a huge variation across municipalities in terms of the type of policies implemented, the adherence, and healthcare utilization, the contraction in healthcare utilization. So we have many questions to answer, much coming from the data. And we see that the implications of answering these questions should lead us on how to design and define policies that are appropriate and effective at the municipality level, and that we need an urgent need to adjust and continue with healthcare promotion and disease prevention strategies. And finally, we need to find a way to provide access to preventative care, depending that now it depends on the migration status, on having a permit. And this affects disease burden and health risk among Venezuelans. So we need to think about to change that in terms of how Venezuelans are provided healthcare right now in Colombia. And I'm going to stop there for now. Thank you.
Thanks a lot, Dr. Harker. I think this is really interesting and impressive study, and I'm very keen to the discussion part where we may explore more questions and comments. Our second panelist is Dr. Karin Diakonou. Dr. Diakonou is a research fellow in the NIHR Global Health Research Unit on Health in Situation of Fragility at the Institute for Global Health and Development, Queen Margaret University at Edinburgh. Dr. Diakonou is interested in health service delivery and health system function in low and middle income countries and the humanitarian settings. Her current work focuses on understanding the resilience of health system and how to strengthen this in situation of extreme shock, including the COVID-19 pandemic. Dr. Diacono will present her work on health system and community responses to COVID-19 among Palestinian refugees in Gaza and Lebanon. And I also should say that I had an honor to work with Dr. Diacono in different projects, and this is really a privilege. Dr. Diacono, the floor is yours.
Thank you very much, Fuad, and the honor is mine, both to have worked with you, but equally to be able to present today. And I'm doing so on behalf of a lovely research team, both at Queen Margaret University and at our partner organization, UNRWA. And for those of you who do not know UNRWA, this is the United Nations Refugee and Works Agency for Palestine refugees in the Near East. And I'm going to provide a little bit more of a kind of context on that in a second. So our study is very much set up as a UNRWA case study. And what we're interested in really is understanding the effectiveness, equity, acceptability, and scalability of strategies put in place by the UNRWA health system in diverse contexts. We're interested in Gaza and in Lebanon specifically, mainly because we know that there are substantial differences in these two settings, but equally because UNRWA shares a common model of service delivery, including, for example, the delivery of primary healthcare services, social care services, and very much working with other agencies to ensure access to secondary care or hospitalization. And so what we really want to understand is how has COVID-19 impacted the organization and community needs. We're using various methods to do that. And today, mainly, I'm going to speak about insights from our interviews with healthcare professionals at UNRWA, different UNRWA health system levels, so in different areas of Gaza and Lebanon, equally at country level, but also at headquarter level in Amman in Jordan. And just as a very short kind of background, so as you can see across the different settings that UNRWA operates in, which include West Bank, Jordan, Lebanon, Gaza, and Syria, there are different numbers of cases, obviously with West Bank dominating in terms of COVID-19 cases, but with Lebanon and Gaza presenting relatively similarly in terms of profile. It's very important to note that in this context, transmission of COVID-19 really accelerated in summer months, rather much later than in Europe. So in some ways, the organization had a little bit of time to prepare, to understand community needs, but equally then to respond to these effectively. So again, this is just a little bit of an overview of the situation in these different settings. We're focused very much at specific camp settings, so very much crowded settlements, but here I'm providing an overview more generally of Gaza and Lebanon. And as you can see, the transmission is primarily in communities, but there are relatively low staff case numbers and particularly low health staff number cases, as you can note. So I'm going to spend a little bit more time on this slide in particular, mainly because it's important to understand how UNRWA has responded at both community level and at health system facility level to address community needs. So there are various needs that UNRWA was aware of very early on. So for example, the need to inform the population of the kind of different strategies that they should be enacting. So they conducted a lot of awareness sessions, produced communication materials, which really tried to summarize risk and key public health advice relating to COVID-19. A lot of emphasis obviously on hand washing and on distancing. Equally, in many cases at community level, there was technical guidance, for example, in Lebanon issued around potentially screening, particularly in areas that had high density of population. And then equally, it was important to communicate to the local population what would happen in case a case was confirmed. Should they be quarantining at home? And if so, what would be best? What would UNRWA do in order to ensure, for example, food distribution? And as you can see from this list, there's quite a number of things that were done to ensure that people were made comfortable at home. So as much as possible, really liaising with local NGOs to deliver packages of food, for example, hygiene kits to people who were isolating. Sometimes equally adopting home delivery as a new food distribution methods. So UNRWA would have done this anyway, especially for those in need, but equally now trying to adapt to a new way of doing this distribution. Equally trying to understand for particular groups. So again, our emphasis was very much on understanding the equity of the response. So obviously people with disabilities or people with chronic conditions, making sure that they would receive home visits and making sure that medication, for example, for chronic condition would be dispensed to them. And all of that is very important, but equally, I think the agency placed a lot of emphasis on psychosocial support. We heard a lot about different well-being check-in calls being put in place for people who were affected by COVID or their family members, and assessments really of psychosocial need. So again, at community level, there's quite a comprehensive response that had been put in place. And at health facility level, it's the usual response that you would expect in case of an infectious disease. So again, for example, making infrastructure changes to ensure that the flow of patients is controlled throughout the facility, triaging effectively, supplying staff with appropriate PPE, making sure that different surfaces, high-touch surfaces, were frequently disinfected, but equally ensuring that consultations were not always attended in person. So a lot of emphasis on creating a toll-free line, for example, for remote consultations, which is being accessed quite frequently. The middle red line really emphasizes that while some of these responses are new to COVID-19, a lot of them are actually similar or familiar to UNRWA responses in general to crises. So at the bottom, you will see, for example, distribution of cash assistance to refugees, the creation of new emergency teams, or dispensation of medicine stock over different months. Those are strategies that UNRWA has enacted often because it has often had to deal with insecurity-related challenges, displacement. But the strategies at the top of this slide really highlight the specific things that were put in place around COVID-19. So very quickly, I just wanted to reflect on the fact that to meet community needs and to really secure gender equitable community health, well-being, literacy, we're talking about systems needing to be resilient. And while some of us really critique the concept of resilience in general, I think for health systems to be resilient, we're really talking about different ways for the system to self-organize and sustain response at different levels. So this is a framework of resilience that we actually developed in a previous grant with UNRWA, and that really tries to identify the different strategies that and also underlying capacities the health system needs in order to deploy strategies. There are three strategies in particular or types of strategies we talk about: absorptive strategies, adaptive, or transformative. Absorptive strategies really refer to the kinds of things that a system would do normally within their kind of resource envelope. So for example, in our case, when staff told us about enacting task shifting to assist with service delivery, putting in place more infection prevention and control measures, or working, for example, with social workers providing psychosocial support, those were things that the organization was already able to do and already had processes for. But at the same time, it adapted very quickly. So for example, the introduction of toll-free lines, putting staff teams in place outside of clinics and triage teams, adjusting the pickup and delivery of medications, or establishing isolation centers. Those are new ways of doing things that were specifically put in place and may be sustained for a short period of time. Equally, what is interesting to note is that UNRWA is now discussing how to transform, understanding that COVID-19 is not just a potentially short-term shock, but that potentially it might affect the organization for years to come. It's important to understand how, for example, to sustain their usual way of delivering primary health care, the family health team approach, for the long term. Finally, I'm going to just talk about three different, one challenge and two enablers, again, drawing on that framework of resilience that you've seen, which I think summarize some key messages that might reflect also, or might inform other health systems. So one challenge that UNRWA faced specifically, for example, is the information systems being in place, not really capturing the information that was needed to make decisions. So for example, the organization wanted to dispense cash assistance to all refugees living in a specific place, but identifying those refugees, in this case still living or residing within Lebanon, was very difficult. And yet this is a problem that the organization is now facing and needs to tackle in order to dispense this assistance effectively. There are two very big enablers that we want to stress. So in one case, what we've heard from our participants in interviews is that strong staff links, inclusivity, and distributed control really helped them make quick decisions. So what we mean by that is that really views at the different levels of the health system can rapidly inform decision-making. For example, the decision to repurpose school spaces into medical points was done very quickly in Gaza, and that actually helped put in place a strategy for the local community and also reassurance. At the same time, another enabler is the willingness to learn and the dedicated space that the organization actually affords learning. So for example, in Gaza, again, a team was convened to elaborate a food distribution system. It was told that they would have to pilot this, evaluate it, and then only engage in scale up. And again, all of that, and throughout that, participants told us that they were encouraged to reflect and learn in order to put in place better responses. And I'm going to stop here. Thank you very much.
Well, thank you. Thank you very much, Karen. This is really another impressive presentation and study. And also there are a lot of questions to be raised on this one. So our third speaker and discussant for today is Dr. Akihiro Seta. I would like to invite him for a brief response to the two presentations and studies. Dr. Seta is the Director of Health at the United Nations Relief and Works Agency for Palestine Refugees in the Near East, UNRWA. He is the chair of the UNRWA COVID-19 coordination body and a leader in health reform, successfully converting UNRWA health services to implement best practices based on universal health coverage. He leads development of UNRWA's strategic approach to the COVID-19 pandemic and guides UNRWA department to implement and monitor the health response. Dr. Seta, the floor is yours.
Yeah, good morning. Do you hear me, Fuad? Okay, so my name is Seta. It's a really honor to be here with the distinguished researchers, Dr. Hakka and Dr. Karen. And it's a really honor to be here. And it's very interesting studies results showing that how health systems are trying to respond to the increasing needs for the displaced and the refugees in the world. As Dr. Fuad mentioned at the beginning, that we have 80 million displaced and 26 million refugees in the world, and all of them are vulnerable. And so how we can maintain the health needs of these vulnerable people are the main question of today, I believe. And both of them that Dr. Hakka mentioned that how that the refugees from the Venezuela showing the behavior, health-seeking behavior differences. And also Dr. Karen mentioned that how the health system for Palestinian refugees, UNRWA, which I'm working for, is trying to absorb or adapt or transform the system to respond to the increasing needs. And I think that the lessons are, many lessons are there. But I think that just going back to the bottom line for the care of the refugees and displaced in the world under the COVID is, the first thing is that they respond in the existing needs. So in Colombia and also the Lebanon or Gaza that both researchers mentioned, how the health systems are responding to the existing needs, because they've been there. Colombia, Venezuela are relatively new, but the Palestinian refugees are almost 70 plus years. I think that's also the basic question, how they responded before the COVID, because that it's impossible that we can respond to better in the pre-COVID era in the reality. And how we are responding to the COVID needs, in particular that for the refugees, the most important thing, they need to be, they should not be left alone in the national response to the COVID-19 or displaced, because that leaving them alone is not only the sort of damage to the refugee and displaced, but the damage to the host country, because that the infection still continue within that marginalized population. I think that is a worst thing to do, last things to do in the infection disease control. So do they have the test, access to the test, hospitalizations and the treatment, including financial access, and then including that access to the highly life-saving intensive care unit and others. I think that's also a very critical issue we need to learn from today's discussions. And on top of it, I think Dr. Karen's presentation clearly stated that actually that what COVID affects is not only health, it's entirely life. And the UNRWA's example of cash assistance of Lebanon is very important. And I'm quite sure it's same for the Venezuelan, say, refugees in Colombia. Because COVID-19 makes vulnerable people to more vulnerable, and it affects entire health. And it affects the entire life at large. And so that the health system response can only be effective only when we respond to the entire their life needs of the refugees and displaced. I think these are the key questions we need to discuss and understand, and how this research can identify that we are responding to the real needs of the existing health needs and the new health needs, and also the worsening life needs. That's all for me. Well, thank you very much.
Well, thank you. Thank you very much, Dr. Seta. And I think this is also a strong input from you. Before we start the discussion, actually, I want to ask our technical support to launch the question for our attendees and give a sort of 1 minute to answer that. So the launch will be, the question will be on the poll on the platform, on the HSR platform. So please try to answer these questions, just to have sort of what sort of questions we need also to raise to our panelists. So I think the questions are there, so you can already start.
Yeah, we have some responses coming in now.
Great.
So I have the results of the poll. 28%. So the question was, what do you see as the highest priority concerns for health systems actors in meeting needs of refugees and IDPs in response to COVID-19? 28% said preventing infection. 25% say improving public health communications and tackling misinformation. 18% said addressing impacts caused by access barriers to healthcare. 18%, the same amount, say providing healthcare for those infected. 8% said providing tests, and 5% said other. So if you put other, please feel free to write your response using the discussion forum function. Over.
Thanks a lot. Thank you, Cordella, for that. So actually, our panelists raised a very important ideas and topics for debate. My question now to Dr. Arturo Harker. So, Dr. Harker, so given the context, in Venezuela, in Colombia before the COVID-19, can you elaborate a bit more on the situation, on the health system situation before the pandemic, and how that context actually affect the response strategy to address the Venezuelan needs?
That's a great question, Fuad. So before the pandemic, as Seita mentioned, and all of the vulnerabilities of the system became more evident with the pandemic. Everything, the vulnerability of the populations was exacerbated. So before, the issue we had is that most of the care in the system no most, but an important part was coming through emergency care units, not through primary care units. And the reason for this is that the persons that can't access the system because they're not enrolled have a right by constitution to access emergency care services. So most of the services were started from there, which is not at all efficient, and in a pandemic it's even more not efficient. So our problem with dealing with the Venezuelan migrant crisis and connecting those two dots is that the estimates are that we have between 1.5 or 2.5 migrants, Venezuelan migrants in Colombia, and only 750,000 have a permit to be here in Colombia. And immediately when you have that permit, you have access to the health system, but then we don't know how many people are not enrolled and are not even going through the emergency care units, like entering to the system through that. So that's one of the main issues that has to be resolved, giving access, and that access not depending on this formal permit.
Yeah, it's interesting. Thank you. Karin, this is not the first time you worked in the region and also on this issue of stressors and shocks. Well, to what extent do you see COVID-19 is different from other stressors, among Palestinian refugees in the region, and how in the response to this shock?
Yeah, thanks, Fuad. I think it's interesting, and I'm going to pick up an idea that I think you also mentioned very frequently. I think in some cases we know what the shocks can be, and I think none of us, if we have a medical background, would be surprised that an infectious disease would suddenly come up that we've not had a response to. I think what is definitely interesting is to see the different type of preparedness by the various different health system actors that are active in the region. And so we're conducting quite similar work, for example, in Lebanon, and it's very interesting to note how UNRWA, relatively speaking, moved quicker and had more awareness of needs. I think very much as Dr. Sita was saying, it's a population that's well defined. We know what the needs are. We know how to potentially address them. Obviously, we can strengthen that. I think absolutely. There are definitely constraints to everything. But in that sense, I don't necessarily think it's a new shock. It's just a shock that maybe we hadn't anticipated, particularly here. But having said that, again, we had quite a bit of time to prepare for it. So I think that's worth bearing in mind.
Yeah, thank you. Dr. Setta, do you think that, as you're leading, this entity since long time, do you think that the policymakers, engaged in sort of say shaping the question about the issue of what are the needs, how these needs can be addressed, or this is mainly, I don't know, UNRWA or academician job?
No, I think COVID itself is beyond the health, and then I think health alone response will not take us anywhere, to be honest, if you see the rest of the world. But let me go back. In early days, our initial response was quite largely on public health, providing a PPE and the social distancing, all the other, making health centers. But as time goes by, the realization is that this affects their economy, this affects their life. So cash distance is more important. I think we learn a lot through this process. And what we learn most is that the COVID revealed the most vulnerable part of the society more vividly. And that's the reason we need to respond to this one. So back to your question, I think it's an entire policy, and as many countries in the world, the COVID-19 should be a national response, not the health response. And the main problem is, of course, health is a problem, but main problem is the economy and the many other things.
Yeah, thank you. Actually, there are a lot of questions from the audience. So I want to bring some of these questions and maybe back to the, some prepared questions that I have with me. So, so there's a question, a good question from Catalan. So, how can we make sure that the voice input of refugees and IDPs are reflected in developing an effective response to COVID-19? So can someone, or both of you try to answer this? Let's say Arturo, how you feel that?
So it was thinking about that. So there's there are ways. We are doing this telephone survey and trying to reach out. It has been a very difficult endeavor because a large proportion of this population wants to keep themselves below the radar because of the fear of being sent back to Venezuela, for example, or the stigma. There is a huge stigma here in recent days in Bogota. We had some things about stigma on Venezuelan migrants. So it is possible, and the technical part on reaching them out can be overcome. But here in Colombia, we have an important factor, is that the violence. Violence is not the armed conflict with the guerrillas. That's very important. Still, we have things are getting worse in terms of violence. And I've heard from leaders from organizations from Venezuelan migrants that they're receiving threats. So it's supposedly not difficult to do it, but the violence factor here in Colombia makes it a little bit more complicated, because their willingness to speak out and to seek help gets diminished as violence is hiking up again here in Colombia. And this year we have seen I think, I don't have the number exact, but a huge number of social leaders have been murdered. So I think that's one of the biggest factors here in Colombia, violence.
Great, thank you. Karin, any input from your side?
No, I was going to reflect, our study is actually also going to focus on that, and we're planning a survey, again, similar, I think, to Arturo, with communities to understand their input, but equally to understand what might have historically shaped that input. So has it been that they always needed a good relationship, or with the kind of policy arena, or with civil society, and trying to understand, really, does that make a difference to how they might mobilize and therefore influence everything? But no findings yet.
Mm-hmm. Okay, great. Karin, there is a question to you, addressed to you by Sharif Ismail. Dr. Sharif Ismail said that the observe, adapt, transform trial for thinking about resilience is notable for framing only positive responses. This is very good.
It's a very good point. Yes.
So how do you conceptualize, typical or breaking points in resilience? So, how do you link this to this work in fragility?
I think it's well, thank you very much, Sheree, for the point. It's a very interesting one, and it's purposefully why we had to add in that lovely framework I showed you, the positive normative kind of box at the bottom, which speaks about you want the system to deploy this absorptive, adaptive, and transformative capacity really to secure equity, health, well-being, community engagement. But you're absolutely right. You could be adapting in a very maladaptive way. You could be putting in place or transforming in a way that actually reduces your ability to either deliver services or compromises delivery to key groups and marginalized groups. So I think the way we conceptualize that is very much by keeping that normative angle in mind, and then trying to understand what may or may not constrain it. So a very kind of quick example in our work, when we were looking at particularly responses in Gaza, And when our participants said, well, open leadership, distributed control makes a difference, and we immediately tried to understand, but what was the effect of that? Was it a positive net effect in the end, or was the effect potentially detrimental to something else? So really trying to follow through the decisions and the capacities to understand where they actually deployed in a positive way towards a goal.
There is another question to the panelists, but I want to ask Dr. Seta before going to this question. Dr. Seta, you actually were in this, long-term conflict and instability in the region, addressing all these needs. Did you see any difference between what's called a sort of natural infectious disaster like COVID on the Palestinian refugees, comparing with political war context, like what happened with Palestinian refugees that moved from Syria? Any difference in the sort of policy process, the response, even in the mechanism of the resilience by UNRWA?
Yeah, I think both of them are, say, disaster or big shock. And there's no need to compare which disaster are more disastrous than the other. Both are disaster. And then COVID is a big shock, and it's we never experienced, not only us, but the world never experienced. And the issue is that at the end of the day, I hope that we will find the vaccines, we will find the treatment, and end of the day that we will somehow, it's very difficult time, and like Lebanon, like I saw Colombia cases are going up, and then we don't know what is the end of the tunnel, but we know there is a tunnel. In Arabic, we say, inshallah, that if everybody works together and the vaccine comes in. While the Palestinian disaster, I don't see any end of the tunnel light yet. And so that this is never ending. I'm sorry to say at this point of time. Let's see that the new regime in the United States may make things better. We don't know yet, but still that is also ongoing disaster. So I think that under that disaster or under that stress, COVID came in. So in one sense that we have an experience of stress, but I think both are extraordinarily difficult one. But I hope this COVID stress will disappear within 1 year time. I hope. Yeah.
I hope so. Thank you. There's a question from Anne Harmer to the panelists, and also I would like to have your input on that. So Anne asked about I'd like to ask to what extent you think your research findings will influence the health systems in transformative ways. Are the respective authorities sufficiently engaged with your research to be committed to learning from your finding and adapting their approach? It's a good question about engaging the authorities. What do you think, Arturo?
So we're making a conscious and I hope enough effort to keep policymakers engaged, especially at the local level, given the focus or the study has. So we have a consortium like where we're periodically showing our advances and the design of the study, but also since the start, we've been engaging with local governments to have a contact point with local migrant communities. So it has been like that, and we have the commitment of, when we have the analysis, when we have the final conclusions, to go back and to share and to try to interpret with them. So that's important, and it's important also to keep the communities engaged in the study, not only the policymakers, but also for example, the migrant organizations that are the vocal, the ones that are trying to do the lobby and to push forward to improve the situation. They also are really appreciative of having this evidence at hand.
Yeah, thank you. Although the same question should be raised in the Middle East region, where UNRWA and functioning. So I would like to ask you, Karin, the same question, but to be honest, I'm curious to know what Dr. Seta, as the one who is in that deal of with the authorities, in the region, thinking about, the same question. So how, as the question was put by, and are the respective authorities sufficiently engaged with your research, to be committed, with the finding? Dr. Setta?
Sorry, you are asking me. I thought you were asking Karin.
No,
yeah, but the question is not to the panelists, it's to you, to be honest,
Yeah. I mean, for UNRWA, yes, committed. If you ask the host country, it's really depends.
Yeah, authorities in the host
country. Host countries, and say like in some host country like Jordan, that we are part of the community, so they naturally included in Palestinian refugees. And sorry to forward, but in Lebanon, that the continuous exclusion of Palestinian refugees remain as it is. And then, as I said, the bottom line question is like are we having access to the test and the hospital care, including financial access? The answer was no. And one big reason Lebanon is also financially bankrupted, so we understand, but still that we have to pay for the test, we have to pay for the admission. So it really depends on the mutual relationship before COVID, and it is somehow continue like this. Is it okay?
Yeah, it's okay. Karin, as an academician, as the researcher in this topic, what do you think about what Dr. Setta mentioned about this engagement, from your perspective?
Well, I think we should notably say that it's Dr. Sita who approached us to basically do the study and to actually work on this. And so in that sense, that's a very critical milestone for everybody to realize that the organization is very open to learning. And I should also mention, we're not the only study that is currently active within UNRWA trying to understand. But I would very much agree. I think what's very interesting is we've had unprecedented access to everything with UNRWA itself, but that doesn't mean that the host country context doesn't play a huge role also in terms of who do we actually give our findings to. It might be that UNRWA cannot action certain things because of other political situations.
Okay, wonderful. Just before closing this very interesting discussion, I still have one question in my mind before wrapping, but I want like a very quick answer, Dr. Arturo, about did you see any difference between, back to your question about the, some municipality work different from others. Did you see that in your finding, or do you think that?
So we do see that at the municipality level, they did different things, very different approaches and strategies, policy making, but we haven't linked that with the result of, for example, infection, mortality, like it drops in the welfare of the people. No, yeah, we haven't done that link yet, but we're eager to that.
Yeah. We still have time before wrapping up, and I think one of the other concern is to what extent actually the local communities engage in sort of in this sort of the strategy of response to the COVID-19. What's your experience in this research, Karin?
Yes, so I think, as I said, it's one of the things we're particularly looking at, but I think there are two types of response that might be notable. One is actually influencing, for example, how services might be delivered or changed or so on. And so we've seen in terms of even just adaptations that our health or social care workers were speaking about, it's very clear it's communities' voices that have been heard and therefore changes have occurred. But then there's the other kind of side of actual community response. So how do communities self-organize? How do they potentially, maybe they have certain rules that they now follow informally that we should maybe understand better. And I think that's what we're focused on in our next kind of step, and equally the experience of that and how they perceive that. Again, UNRWA is their main service provider in this sense. How have they been not just heard, but equally, how have they been able to actually make themselves heard and to also by themselves maintain their well-being? And I think in that sense, it's also really important to understand the conditions differ drastically. So even across our health and social care staff, what we keep hearing is obviously that the economic situation is much more dire in many cases than is COVID-19. So again, the priority of communities might be completely different to the kind of questions we're asking.
Interesting. So can I ask each one of you a sort of what could be the key messages to the policymakers in 1 or 1.5 minutes? You can answer. Arturo, let's start with you.
Thank you. So I think I would focus on two messages from the perspective of the health system. The first one is the one we've seen all around the world, that is we need to urgently adapt to continue to do health promotion and disease prevention. Having this pandemic, well, health systems had been in shock. So there's this supply side shock, but also from the demand side, what we've seen and what we've seen in the data is there's a huge contraction. People are afraid or aren't getting the services they need to prevent diseases, and that's the most efficient way to deal with the disease burden. So that's one. And the other one is we need to rethink how the Venezuelan population is accessing to the system, the healthcare system. And this is something I've said already. It's a population that is afraid to be registered anywhere if they don't have this permit. It's obviously a risk they perceive, even if it's real or not real, that they're going to get deported. So the system has to find a way to give more permits or just to give access to primary healthcare without that permit. But we have to start thinking outside of the box on how to reorganize and how to connect the migration status and that whole part of the policy with access to healthcare. That, for example, in education, it has been easier because children here in Colombia have, no matter their from what country they are from, they're guaranteed access to health and to education. But for other age groups, that's not true. So that's the second point there. I would.
Yeah, this is important. Thank you. Karin, we have time, so
so I can have 2 minutes.
you have more than, yeah.
Okay,
So
no, I mean, we can give it back.
Or you can give it to
I could give it back to Arturo. Yeah, I think from our study, our main messages really for policymakers, or for our practitioner audiences, really are learn from what you know. I think, as Dr. Sita has already said, at the beginning, a lot of the response was public health response. It's the normal response that we've already known how to do in different conditions. Equally for UNRWA particularly, it already knew how to deliver a lot of its usual services in a different way. And in this case, it was just a kind of tweak to those new services. So whether you dispense medication for 2 months, you're still doing it the same way. Maybe you have different pickup points. Maybe you have different phone consultations now as well. Maybe there are different sudden ways that you need to do things. And I think one of the things equally that we've often heard, and I have to reflect here, not just in the current work, but also on previous work we've done with the agency, also with you, Fouad, is you learn from what you've done, but equally you're not afraid to make a mistake. And there's no blame culture within the organization. It's, yes, something has been done, it didn't work well, okay, we're going to modify it. It's not a case of somebody losing a job or a clinic might close for a day or two. That's okay. We're still going to, as Dr. Sita says, see the end of the tunnel at the end of the day. And as long as we can manage with that, then that's important.
Thank you. The floor is yours, Dr. Sita.
Thank you very much. I think the message to the and the COVID politics go wild in the east and the west and the north and south. And I think our message to the politicians should be based on the health value, which is to take care of each one of the citizens within the country. I think that this is the best time to raise the importance of this universality or equality on the health services issue. I think that's the best one is this. And the reason is very clear that if you don't take care of the Palestinian refugees, for example, Lebanon, COVID will never be eradicated or whatever happens. And the same for the rest of the world, the immigrants, same in Colombia. If you don't take care of Venezuelans for the COVID, Colombia will never get rid of the COVID. I think that's the very basic message, I think, for this and the importance of this one. And I think this is a great opportunity for the health systems, people to be more inclusive and having access to everybody, having access to all those who are in need and establish a good financial system in the future. I think in Chinese or in Japan, we say changing the disaster misfortune to fortune. I think that's what we're reading, and that's a part of transformation, like Karim mentioned. I think that's the biggest challenge. I think absorption and adoption is more in the capacity of the health system, but the transformation is really brain work, and I think that's a very interesting part to do this. And last not but least, the politicians that protect the health staff. Karim mentioned that a number of UNRWA staff infected, but it's increased. It's almost 800 in total, 165 in Lebanon now. And so it's continuously on the rise. And I think it's important the politicians to protect health workers and they give all the support they need. I'm talking to myself though. Okay, thank you very much.
Thank you, thank you. You know, although I should be only the moderator, but I feel like I'm very eager to think about that also in this way about the issue of health system in a humanitarian settings. And to what extent we should put that only as a sort of parallel system to the other health system, regular health system. And then again, this word of universal health coverage. So to what extent this word universal is really universal? So we address the needs of different population, regardless of their, legal status, regardless of, the sort of the label that sometimes they carry on. I think there's a need now to think about, COVID is not just a health crisis. It seems like other health issues, it's not a technical issue. I think it could be put in the wider, let's say, issue and wider concept where we need to address, the politics, the economy, the society. So it should be approached from more broader rather than just focusing on this technical health issue. I would like to thank you very, very much for this very, informative and impressive presentations and comments from Dr. Sietta, and also would like to encourage the audience also to know more about the other R2HC studies by visiting the R2HC website and check, these different studies related to the humanitarian crisis. Thank you very much, and looking forward to more collaborative work. Thank you. Thank you all.
Thank you very much.
Thank you very much. You.
Thank you so much.
Thank you.
It was a really good session.
I just need it for